Sejam bem-vindos a esse episódio do Hematocast. Meu nome é Karina, sou médica hematologista e hoje eu tenho o prazer de dividir essa sessão com a Júlia, que é médica hematopediatra aqui do Einstein também, e a professora Staci Arnold, que é professora na Emory School of Medicine, em Atlanta, nos Estados Unidos. E a gente vai discutir um pouquinho sobre terapias curativas, o acesso às terapias curativas na doença falciforme. We'll have to record this in English for logical reasons. So thank you both for being here. I'd like to start asking Professor Staci Arnold to give us a brief overview of what were the main barriers for access to curative therapies for sickle cell patients in the U.S., and then how you could overcome these barriers to guarantee access to such therapies for patients.
Sure. I think in order to answer that question, I actually sort of have to lay the landscape of gene therapy in the U.S. So prior to the approval of the two products for sickle cell disease in December, we actually had a number of gene therapy products available in the U.S. for hematologic and non-hematologic disease. I think the most relevant was the approved product for beta thalassemia. Regrettably, in that time, though, two of those three products have actually been pulled from the market because of expense and inability to access. The thalassemia product has been largely accepted at many institutions, and here recently is now available at our own institution as well. But I give that reference because I think that impacts what we're doing with sickle cell. And in the U.S. in particular, part of how coverage is determined is by your insurance. And the leading driver there is our government agency insurance, and that's the Center for Medicare and Medicaid Services. In most circumstances, their approval opens the door for private insurance companies and others to approve their gene therapy products. And so that's at least the landscape we were approaching when we knew these treatments were becoming approved in December. In fact, though, we've actually seen some private insurance companies already in advance of the CMS decision say that they'll take on gene therapy. And I think that's in part because they see what I think we know is that caring for someone with sickle cell is quite difficult and quite costly. And there potentially is a benefit to doing curative therapies like transplant and gene therapy to mitigate that cost over a lifetime. So right now, we're still awaiting the CMS decision on gene therapy, but we're all very optimistic that that will then provide access. In the meantime, our patients are also able to access gene therapy through clinical trials. But in terms of barriers to all of these, it's cost and insurance coverage, it's knowledge and awareness. It's also having provider expertise and ability to perform these treatments. Again, we're fortunate in the U.S. that we have a number of sites either comfortable with transplantation or gene therapy. And all the other sort of psychosocial demographic variables that come into play when we talk about not only accessing, but then participating in these curative therapies.
Okay.
I'd like to ask you about Dr. Staci, about how do you select the patients, bone marrow transplantation versus gene therapy?
That's a great question, and that's going to be a challenge we will have to face. We fortunately have had some of this experience with even just having available institutional trials that sort of have the same patient population. And so in those settings, what we've done is just presented both to families. Okay. So we will have that luxury of being able to present to individuals, here are your options. These are the pros and cons of each. Given that, what do you think? And then continue to have a conversation. I think you both know doing transplant, it's not like one conversation and then you go to the therapy, right? There are numerous conversations, numerous consents. And so it's an iterative process. In particular, though, obviously anything done under a clinical trial, that selection criteria is predetermined and mandated. Then outside of that, though, when we're talking about these commercially available products, it then depends on these conversations. Now, what I will say is, at least in our group and in our institution, we still believe matched sibling donor transplant is the preferred option. So I guess when I'm talking about gene therapy and these other therapies, that's separate, and in a category of its own, because I think the evidence and data behind that is longstanding and proven, whereas we're still learning about haploidentical transplant and gene therapy and the long-term durability and outcomes of those products. So when we're talking about other therapies, that's at least we're at our institution where we can lay out match and unrelated donor transplant, mismatch unrelated donor transplant, haplo and gene therapy, and determine. I do believe there are tendencies that really just have to do with the patients and families themselves, their degree of willingness to accept certain risks, their ability to access the various therapies, and so there's not a one size fits all. So it will be a conversation with each family, and even taking into account that child specific sickle cell complications going in, because as you know, with gene therapy, stroke was not allowed on the trials. And so a number of complications we just actually have not seen gene therapy used in. So we're going to have to learn that experience as well.
Yeah, and it's not only that it wasn't allowed. Most gene therapy products that have a lot of success in clinical trials and now for commercial use. Well, not most, because for commercial use you have one that improves production of fetal hemoglobin and other that makes production of hemoglobin A.
Right.
So for hemoglobin, but we know that there is like a lot of gene therapies coming, and most products will focus on improving hemoglobin F production.
Right.
Which is very tricky for patients who had a stroke or who have cerebral vasculopathy. And this is something very important that we have to take into account, meaning that so far, there are no evidence pointing that we can treat these patients with fetal hemoglobin gene therapy products, because we don't know how cerebral vasculopathy will behave, or if these patients, they will be free from stroke in, 20, 30 years. Yes. And because most patients that will undergo curative therapies will be children. We do perform this in adults, but in 20, 30 years, we expect them to be free of stroke. Otherwise, we have to question if this is worthy, because this is a very severe complication. Right. So I think this is something really important that we have to take into account, which kind of complication the patient had prior to the curative therapy, right?
Yes.
So,
no, you're exactly right, and raise an excellent point. And I think when we have these conversations, I think it's a lot of the sort of layperson's discussion of gene therapy, but that's not a one size fits all, right? And as you said, there are a lot of different gene therapy platforms that address trying to cure sickle cell in different ways. But what we do not know is if the hemoglobin F approach is sufficient, or the hemoglobin A, or even the modified other hemoglobins or other platforms will actually have some of the success we've seen in transplant, where we not only see halting of end organ complications, but reversals. And so that will be important to know and understand as we're moving forward with gene therapy. And at least from what we know so far with the hydroxyurea experience, we know that even with good fetal hemoglobin, you still have sickle cell complications. And so it's yet to be seen if a compliance-insured gene therapy that raises your fetal hemoglobin is enough to bypass that, or if there still will be some end organ damage. And, the studies really looked at pain, which, of course, we all know pain is an important part of sickle cell, and any effort to rid or reduce that is key. But again, there's a lot more to sickle cell. It affects every organ system in the body. And so we can't just look at pain when we're talking about these cellular and curative therapies.
And there is another point, I think, which is related to this, because I don't know, I tend to think that when you have results from matched related transplant, for example, most patients will behave like an S trait, which we know from nature that is an S trait. Okay, they might face some complications, but normally they will be fine until the end of their lives, and they will live just as much as people who don't have the sickle trait. But a patient with sickle cell disease with hereditary persistence of fetal hemoglobin is a patient with sickle cell disease and hereditary persistence of fetal hemoglobin, meaning that we don't know exactly how these patients will behave and how long they will live when they get older and older. So what is cure in this sense?
Right.
And do insurance companies, how can I say, what is their view about, is this really a curative therapy? Is this worthy, something that is worth investing in terms of a lifelong landscape, let's say?
So I think if we in the medical community don't even know what that looks like, certainly an insurance company doesn't know. But again, the early trends and even our response to gene therapy in the field is that we're optimistic that, even if it maybe is not a true cure, it certainly is enough to make a substantial impact on the quality of these individuals' lives and their healthcare utilization, such that it's worth that expense and that risk of a gene therapy. But you're exactly right. I mean, in fact, we used to say that SHPFH is like trait, and, you'll grow and be fine. But there's some emerging data from Kuwait in the Middle East that actually says that either that fetal hemoglobin starts to decrease over time, and or you start seeing some actual complications. Now, again, with gene therapy, if this truly is a durable increase in fetal hemoglobin that maintains at high levels for 20 to 30 years, then maybe we're not even seeing that experience. But again, it's a little too early to say. And so, in the meantime, we have to have these conversations about, this particular patient with these particular set of complications and this age, right? Because gene therapy was also just studied in teens and adults. There are newer trials in younger children. All of those factors, plus, the family circumstance, the available donors in the U.S., we can't assume that, unrelated donors are available. And so then you're really talking about potentially haploidentical transplant or gene therapy. And weighing the risks and benefits of those for each patient.
Talking about risks and benefits, I think our main goal, as I said you earlier, is quality of life for these patients. And you just published a paper about it. So can you talk a little bit more?
So what I will say is, the vast majority of those patients were matched sibling donors. However, at our institution, we've had a broad experience. So there were included patients who had haploidentical, even not in the publication, but in the cohort, we have a couple of patients who got gene therapy as well. So what we're ultimately trying to do is look at the long-term late effects of cellular therapies for sickle cell disease. And the publication specifically focused on those who were transplanted. And what we found that is, at 3, 5, 7 years post-transplant, we're actually seeing the vast majority of the quality of life domains returning to normal levels. So meaning the quality of life of you or I who do not have sickle cell disease or are not affected. And that's great. That's ultimately what we want to see. I mean, obviously, we want patients to survive the treatments and not have graft versus host disease and not have these other complications. Those are the quantifiable sort of research metrics. But truthfully, we want patients to be happy, healthy, going to school, going to work, doing all those things as you alluded to are the end results of a curative therapy. And at least our quality of life data is showing early indicators that they are. Now, again, we compare to these population norms, but as the study goes on, we actually have recruited siblings, so including some sibling donors, as well as patients who have sickle cell but have not been transplanted to be able to compare not only at a finite point, but over the long term, to be able to see if this is really maintained and truly making a difference in terms of their quality of life before these therapies compared to after. So that's very promising, but still more work to be done. And that's just in transplant. What I hope, and at least what I've seen from, CMS and those in controls, they're very interested in also seeing the quality of life with gene therapy as well. So, and as I said, we're recruiting those individuals, and we actually have expanded from our center to 6 other centers in the U.S. as well. So we'll have a breadth of experience to be able to better answer that question.
Very interesting.
And do you have patients only with commercially approved therapies, or patients who are enrolled in clinical trials as well?
Clinical trials.
Clinical trials, okay.
Yes, so we don't limit by sort
That's
of
nice.
source of their curative therapy. In fact, the only limitation is that you have to be at least 1 year from some sort of cellular therapy. So
Okay.
1 year from either transplant or gene therapy, but it could be, I won't say the names of the commercial products.
No,
this
no.
is not a commercial, but it could be one of the commercial products,
Yes.
or it could be on a clinical trial.
Yes, it's important to patients to get access to that, because
Yes.
for our adolescents, for example, 1 year after, it's 1 year very difficult after bone marrow transplant. We are not in gene therapy yet. So maybe it should be something.
Yes.
I want
Right.
to be there.
Right.
I will be
Yes.
able
Well,
to
yes.
pass the
Yeah.
We can show
Mm.
patients like adolescents, for example,
Mm.
who are very, I want this now.
Right.
I'm not a pediatrician, but still, we have some young adult patients. And
Yes.
for me, they're just adolescents as well. So
Yes.
maybe show them, okay, so this year will be really difficult, but in 2 or 3 years,
It's
things will
temporary.
get
Yes.
fine. Yeah.
Yes.
And
Yeah.
you go back to school, you can do whatever, more or
Right.
less, whatever you want.
Well, and so I'll say 2 points to that to clarify. So we know, and actually the early studies after transplant looked at that first year. And we know, in fact, actually your quality of life gets worse, in that first month of transplant, right? You're in the hospital, you're getting all these medicines. Sometimes you don't feel very well. So there's actually that decline from an already lower baseline, but then it starts to trend back up. And what we're seeing, and at least in our work, is that rise continues all the way to a level that's normal.
Okay.
Now, when I say we're in the early phases, not only of the conversations about who's eligible, how do you pick, and understanding the long-term durability and outcomes of gene therapy, but we're also in the early phases of having this kind of information to inform our conversations with families. So, when I talked about access and determining earlier, that's with what we know today in 2024. But as you said, as we know more about gene therapy outcomes and as we know more about quality of life, then it may be, my answer is different, that I'll say X therapy is probably preferred because not only do you have great survival and you're cured of your disease, but you also, are productive, functional, and should have a great quality of life. And so that's the goal, at least. I think we all who do research have that particular goal in mind, that it will actually inform the clinical care setting.
Yeah,
Very
right. So I think that we could cover a lot of issues here. Thank you so much for participating again. I hope that this helps somehow us to have some ideas here on how to improve access as well.
Yes.
So
I hope so too. And I don't know, I will add though, that it's a different experience in other parts of the world. So I shared my experience in the US, but I think it's important to consider the unique factors about where your care setting is, whether that's in Brazil, whether that's in Uganda, Tanzania, India, and try and make these decisions for your patient care setting. But what, again, we hope to do is provide data and information that helps inform those decisions.
Yes.
I think that the main challenge here is that these patients here in Brazil, they rely mostly on the public health system. So we don't have like an insurance. Some patients will have an insurance, but this is something that is a matter of debate. Who's going to pay for that? How this is going to be paid? Because it costs a lot of money. And because for now, most products come from other countries, we'll have to import the product or the technology. So it's really costly for our public health system because of our currency, which is not very, how can I say that? Well, $1 here is really expensive, you know? So in terms of the value of our currency. So this is something that impacts, and who's going to pay for that? This is not something that is, it's still being discussed. So we don't have, as you said, we don't have exactly the same reality that you have in the US because the health system works differently here. But I think that if we have some data to clarify at what extent these therapies, they ameliorate quality of life, then can improve outcomes in general, and mostly when you perform this kind of therapy, how much the public health system will not pay for this patient, you know? So this is something that we have to take into account, like how much this patient would cost having a stroke at 5 years old, for example, and living until 50, I don't know how many transfusions, and how much he's not, how can I say that? Well, I don't think it's the good word, but contributing to society in terms of this patient probably doesn't have a normal life, he's not very productive in the labor way of, you know, saying that someone is productive, but still. So this is the things that we have to take into account. So this kind of data will be very helpful for us to think how we're going to improve access here.
Certainly cost effectiveness and cost benefit analysis can inform that piece. There's also just the continued development. So it's not like the scientific world ends with we've approved gene therapy. We're still investigating different platforms that maybe are more effective, different ways to administer that maybe will reduce the costs. You know, you talked about maybe importing, you know, an external product, but then there's also the consideration of developing products locally and how that impacts costs. Even ex vivo gene therapy versus in vivo. There are all these different facets that I think could potentially change the landscape of gene therapy and can make it more affordable in various settings. And especially if we've already proven that there is a cost benefit to it, I think that makes it even more reasonable in lower and middle income countries. And so I do hope that people don't sort of count gene therapy out just because it currently has this high price tag. You know, I think we learned from the COVID pandemic, unfortunately, as terrible as it was, one of the things we learned was we can actually share, you know, scientific advances and knowledge and deliver that to parts of the world at lower costs. We even have that paradigm already with transplant. And so there's no reason to think that gene therapy won't be the same. And so I'm remaining optimistic, but I also think, going back to how we started the session, we have to continue to think about that so that we're not a year from now in the same situation as some of those other therapies where it's pulled from the market because it's too costly. I think now is the time to really start working with, you know, the companies developing these agents, working with health systems, working with the places that need it to try and get through strategies where we can actually bring these kind of therapies, you know, to communities that really need it. And when we talk about sickle cell, it's not the U.S., you know, it's the rest of the world where sickle cell is endemic. And those are parts of the world where they never will have access to a $3 million therapy. So then how do we either change the therapy or, you know, change the mechanism of delivery?
Yes, that's right. Yes.
Very interesting. It was a pleasure to be with you. I didn't say it, but it was a real pleasure.
Thank you. No, this was a great conversation, and thank you for having me.
That's an interesting discussion. I hope we'll continue the discussion later on this week. And it was a pleasure to have you. Thank you, everyone who's watching us. And Well, thank you and see you next time.